All right, y'all. So we're going to dive further into strokes and start talking about what does a individual with a stroke look like by kind of starting off by keeping it general, talking about some common clinical features that patients may or may not have after sustaining a stroke of any type. First being hemiparesis or hemiplegia. This is what most folks think of when they think of um, impairments after a stroke, is that one-sided weakness. Almost 90% of folks will have some degree of weakness after a cerebrovascular event. What's important is to make sure that you guys understand and refamiliarize yourself with the difference between hemiparesis and hemiplegia. These are two terms that are very frequently interchanged incorrectly and inappropriately. So hemiparesis is weakness that's kind of mild, maybe moderate at most. Whereas hemiplegia is effectively paralysis. It is profound, severe motor loss, weakness. So very, very different in presentations, obviously have very different functional implications. So just make sure you're using those terms appropriately. With our hemiplegia, now you may see an arm impacted more than a leg or things like that. And we'll talk about kind of when we see either at a later set of slides today. But generally speaking, it tends to be worse distally than it is proximally. We'll see kind of a variation of both regardless. But what's really interesting to keep in mind is that our trunk muscles are typically spared when it comes to weakness, or at least, and especially significant weakness. And that is because our trunk has bilateral descending motor pathways that connected to our brain. So when one side is knocked out for our trunk, it still has the other side to take care of it. So you may still see deficits, but it does tend to still remain intact, much more so than the extremities. The cause of our weakness is obviously cortical. We see it coming up from our brain, and then we lose that descending drive. But it whittles all of the implications, whittles itself all the way down to the motor unit. We lose a nice strong motor unit activation. We lose that nice motor unit synchronization with other motor units around it, and it just ultimately causes a significant reduction in muscle strength, torque, force, and that is both when we are static and say doing an isometric attempting to do something isometrically, or in dynamic tasks as well. It's important to understand the difference, and this is the case for any diagnosis, primary versus secondary weakness, right? Primary weakness is a direct correlate of the injury itself, that descending drive loss leading to weakness, but it's super common to have secondary weakness as well after something like a stroke due to immobility, due to not using those muscles as well anymore, due to compensatory strategies that people pick up that they shouldn't. So that's something that we're constantly battling as physical therapists. We want to stay ahead of as physical therapists. We want to educate our patients on ways to avoid that secondary weakness. Secondary weakness is adding insult to injury. It's preventable, but it's very common. The other thing that we have to consider when we talk about a patient's ability to use their muscles goes beyond just the strength of that muscle. We have to pull in the motor control factor as well. And when we have impaired motor control, that is also due to a descending drive from our cortex and the regions that were involved in that stroke. And kind of the way that I like to describe motor control to my patients and their family is when we think about our brain's ability to use a muscle, whether we're walking, reaching, whatever. Half of the battle is having the strength to do it, having that nice, strong muscle grade. But then there's this other half that's often looked, and that's called motor control. And motor control is essentially our brain's ability to use what it's got. And that's just as much of a battle for our brain after it's been hurt. So even if it's got nice, strong muscles, sometimes our brain loses the ability to best utilize those muscles. And that is an impairment in motor control. With impaired motor control, we lose that nice spatial and temporal cohesiveness that we see with normal muscle contractions. Agonists with antagonists, one joint to another, we lose that nice synchronization. So we see spatial and temporal abnormalities in the activation of those muscles, which leads to further functional breakdown. So that's important to consider too. You could have a muscle, say your quads are 5 out of 5 in strength when you do a manual muscle test, but every time they stand up, their knees buckle. Why is that happening? They're not in pain. It's probably a motor control issue. The brain's not using what it's got appropriately. And that's just as much of a battle as getting strength back, and just as important. What we also can see with folks who have had a stroke are synergistic patterns. And this is a result of that weakness, of that loss of or inhibition of that descending drive. The most common synergistic patterns that you'll see, so basically what a synergy is our body's loss of ability to move a joint or a muscle in isolation. So instead of moving our elbow in isolation, if we wanted to bend it, we end up seeing multiple joints moving and multiple muscles contracting at once. It's kind of in a way to compensate for weakness. It's mainly due to that impaired descending drive. Kind of the signals coming down from our brain just aren't adding up and things happen that shouldn't. Two most common synergies that we see where it'll be an upper extremity flexor and a lower extremity extensor synergy. Those are I got nice pictures for you right there. And those are the motions that are typically associated with it. So to kind of best describe this, if you were to pick any, we'll talk about upper because that's the easiest one to kind of picture. If you were to pick any one of those motions, you or I can isolate that movement, no problem. If I wanted to just abduct my shoulder, I'll just abduct my shoulder, no problem. I don't have to move anything else to do so. When we have a synergistic pattern, someone who starts to abduct their shoulder might also elevate and retract their scapula. They'll also it's hard for you to see, they'll also kind of bend their elbow and wrist in the process, supinate. So they'll get kind of this thing happening as opposed to this. If I wanted to bend my elbow to bring something to my mouth, I'll just bend my elbow. Someone with synergistic pattern, they may start to bend their elbow, but then they also get some abduction shoulders. Their wrist starts and forearms start moving in a way that they don't want them to. Their fingers and their hands clench up. So you can imagine that these synergistic patterns make it very difficult to perform specific functional tasks. A great example with flexor synergy, if I wanted to say reach up to something over here, maybe I had one of my kitchen cabinets back here and I needed to abduct, I'm kind of multitasking, I'm chatting with you and I just want to reach up. I need to abduct and extend my elbow and open up my grasp, so extend my fingers too. Someone with synergistic pattern will start to abduct, but then the rest of their arm will kind of do this and they will not be able to extend their arm and reach up. So reaching tasks are really hard for folks. With the extensor synergy pattern, when everything is extending, it's really hard for people to get a nice efficient gait cycle going. You can absolutely have flip-flop versions of that. You can have upper extremity extensor synergies, lower extremity flexors. They're just much less common. To figure out what those guys look like, take all of those movements and flop them, and that is what you will get. Possible, much less common. Dexterity, whoops, getting ahead of myself. Dexterity. So dexterity actually can be used for a variety of different areas of our bodies, of every limb, our uppers, our lowers. Really, when we talk about dexterity, though, especially with post-stroke function, we're talking about the hands and the fingers and kind of our fine motor skills. And this is a really huge problem for folks after they've had a stroke. And it's regardless of how strong or weak those muscles are. The relationship between that isn't fully defined yet. But patients really struggle with being able to use their hands and their fine motor skills to perform quick, accurate, rational, decisive movements. And you can imagine all of the different types of ADLs and stuff like that can have a impact on. It's pretty much across the board. And then we have tone, and you guys know all about tone. You're familiar with tone. I just wanted to make sure I really pounded this in because this is such an easy oversight. I see it mistaken for all the time. Just make sure you really feel good about what kind of tone we're talking about. As I mentioned when we were going over the case study, some of y'all were putting in that someone had hypotonia and hypertonia. That's really not that common. You're going to see one or the other, right? Because they both have different kind of origins, if you will. Now, you can see all different types of tone with a central injury, but you don't really see them all at the same time. It's one or the other typically. Typically, upper motor neuron lesions are associated with an increase in tone. Typically, lower motor neuron lesions are associated with hypotonia. The one exception to that rule here is that sometimes we will see acutely hypotonia in involved limbs initially after a stroke. That tends to change to hypertonicity as the stroke becomes more subacute and chronic. By and large, if patients are going to have issues with abnormal tone after a stroke, it is going to be in some kind of increased fashion, whether it be spasticity, hypertonia, or both. Now, Notice what I just said, spasticity, hypertonia, or both. These are not the same things. You can have both, you can have one with the other, but they are not the same thing. This is another example of when words are very frequently interchanged and they mean two very different things. Spasticity is velocity dependent. You need to move the limb quickly to see a increased tone response, whereas hypertonia is a general term for increased tone, and that is velocity independent. It doesn't matter if you move that elbow fast or slow. If it has hypertonicity, it's gonna resist you. Tone is as a passive resistance to elongation or stretching. And the difference between spasticity and hypertonia is how fast you got to go to get that from happening. Spasticity is what you guys are the most familiar with. It is what you have learned to test. The modified Ashworth scale measures spasticity, not hypertonicity, spasticity. Because if you think about when you learned how to do the test, how do we do it? We quickly move the limb. Okay, it's velocity dependent spasticity. We tend to see spasticity most frequently after a stroke. Where we will see hypertonia is with more severe injuries, and that is in the form of posturing. Hypertonia comes into play a lot more commonly with basal ganglia disorders. So Huntington's, Parkinson's, that kind of thing. That rigidity, that cogwheel rigidity, lead pipe rigidity, that's kind of the hypertonia that we're more used to seeing. Hypertonia is very much correlated with basal ganglia dysfunction, whereas spasticity is what we see when we get that damage to those cortical spinal tracts and our pyramidal tracts. Okay, so just to make sure everyone's clear, we do modified Ashworth for spasticity. Another thing that I picked up on in y'all's cases every once in a while is that some of you did say that you had hypotonicity as measured on the modified Ashworth scale as a 0. A 0 on the modified Ashworth scale is not hypotonia. A 0 on the Ashworth scale is normal. You and I are a 0 on the Ashworth scale. Ashworth does not look at hypotonicity. We actually don't have a definitive way of measuring hypotonicity other than observation and description. So just be careful about that. Spasticity can come with or without clonus. It's due to that descending drive and exaggerated stretch reflex that you guys learned about way back in physiology, and that is typically what we see after strokes. With, as mentioned, kind of the main exception to that rule, the really only time we see hypertonicity in strokes is with severe strokes when we have that bilateral brainstem involvement, and talking about that red nucleus. So decorticate posturing and decerebrate posturing, which you guys are already familiar with. In coordination, you guys know this stuff. This is definitely a review. Just putting it in there to put it all together. When we look at in coordination, so as you're prepping for your practical, there's 3 things that we're testing for: the speed, the fluidity, and the accuracy. Those are our 3 musketeers of coordination. Someone should be able to do something fast, accurately, and nice and smoothly with nice coordinated, beautiful movements. Our movements in our, when we're talking about coordination, they're in a bell curve, right? We start slow, we speed up, and then we slow down to make sure we're accurate at the end. We lose that when we have coordination deficits. When we look at coordination deficits, we look at grading scaling difficulties, and we look at timing difficulties, and there's a lot of different ways that those can show up, which I have listed for you there. This is a great slide to review when you're getting ready to talk through what you're doing on your patient for your practical. So this is a little gift to you to really get yourself well prepared. Okay, and then to wrap up the orthopedic stuff, and then we're going to quickly talk about sensory, and then we'll take a break. Pain. I put this here because, so pain can come in many shapes, forms, and sizes. We'll talk about a little later about how our thalamus can be involved and a lot of central pain after when it's impaired from a stroke. But really the main kind of forms of pain that we deal with or that our patients deal with after a stroke is either neuropathic or orthopedic. And both are very much treated in different manners. Neuropathic is primarily treated with medications, but there's some, sensory play and integration that we can do there too. Orthopedic obviously has a lot of different ways that we can attack it, but orthopedic pain is a huge problem post-stroke, and that is because these patients often have a pretty significant amount of asymmetrical weakness, asymmetric not only left and right, but asymmetric when you're looking at agonists and antagonists, and that leads to abnormal movements, abnormal loading through joints, abnormal muscle length tension, abnormal tension on ligaments and tendons, you name it, the list keeps going on. And that is super, super easy to bring on pain. The most common area of orthopedic pain and orthopedic injuries after a stroke is the shoulder. And that could be all those different things and more. And that is mainly because a lot of times these patients have a decreased strength in their shoulder girdle muscles. MCAs are the most common type of stroke that we will see, as we will come to learn. And that affects our upper extremity more than our lower. And so we will often lose that nicely tightly wound shoulder girdle that we typically have. Our rotator cuff's main job is to keep that shoulder girdle nice and tight. And we lose that. So our arm ends up kind of just falling into gravity. It pulls down, our humerus gets pulled away from our shoulder joint, and that can cause a lot of pain. So that's a huge, huge place of concern for folks after a stroke. And it's not like our spinal cord injury folks where it's an overuse thing. It is due to an abnormal, kind of just a breakdown in overall mechanics of that area. Second most common thing we'll see is low back pain with these folks, and that's because they spend a lot of time sitting. And then kind of all the same reasons that I just mentioned. They'll get a lot of proximal hip weakness, a lot of muscle length tightness, things like that, that ultimately will lead to low back pain. And then, of course, we can see sensory changes, looking at our primary sensory strip and our parietal lobe, looking at our sensory integration pathways, all of our areas of our brain can all lead to a variety of different presentations of sensory loss or impairments. It depends on the area and the type of the stroke. You can have a total loss of sensation. You can have abnormal sensation in the form of paresthesias. Paresthesias can come in a lot of different shapes and forms, most of which I have listed there. Just depends on what part of the anatomy is involved. You can have dysesthesias, so kind of unpleasant, abnormal sensations, or even allodynia, which is painful sensations that shouldn't be painful. So like a light touch would cause pain. All of those can be seen and more after something like a stroke. And then we're going to stop here, take a quick break. When we come back, we will do a quick coverage of visual and then spend most of the next set of slides on perceptual deficits that we will see. So I'll see you there.